Okay, so we're quickly trying to look at the pathology of squamous cell carcinoma. Pathology of squamous cell carcinoma. Alright, so you can just have it and be looking at this picture. Okay. So for this pathology of squamous cell carcinoma, we'll start from the introduction. So it's one of the second most common tumor of sun-exposed skin of older individuals. Earlier on we spoke about melanoma. We said that melanoma was the most common, right? So it occurs more frequently in men than in women, with exception of lower legs lesions. So less than 5% of lesions, they metastasize to regional lymph nodes. That means they will now spread towards lymph nodes of that region. You get it? So what next? Pathogenesis is just usually due to ultraviolet light radiation. Right, that's the greatest predisposing factor, primarily by inducing DNA damage and dampening the immune function of Langerhans cells. Right. So immunosuppression. Sometimes if you are somebody who is undergoing some chemotherapy, right, it reduces the host surveillance and increases what keratinocyte susceptibility to infections and transformation, which is usually caused by what the herpes papilloma virus. Subtypes 5 and 8 are the ones that are actually implicated in this, right? So industrial carcinogens like TARS, chronic skin ulcers, old bone scars, draining osteomyelitis, ionizing radiation, and tobacco and betel nut chewing for oral mucosa, alright, can be acquired or have a germline link up. So p53 mutations, okay, may allow the cell cycle progression despite low fidelity DNA repair of what ultraviolet light damage. So this will now lead to rapid accumulation of mutation and eventual it will now lead to what progress to cancer development. So driver mutations that increase RAS signaling or that decrease Notch signaling also contribute to the transformation process. Okay, so ending with the morphology, trying to describe how a squamous cell carcinoma will look like. So they are well demarcated, they are rare, they are scaling plaques when in situ. Invasive lesions are nodular, variable hyperkeratotic, and prone to ulceration. Histology shows a full thickness epidermal Atypia, right? Invasive tumors vary from well differentiated with prominent keratinization to highly anaplastic with necrosis, right? So that's just it for the pathology of squamous cell carcinoma.